One of the most exciting things for us this year, of course, is that we have a new national coordinator. So, as many of you may know, Dr. Karen DeSalvo is from my hometown of New Orleans, so I'm really excited to have a fellow New Orleanian. She's a physician who's been a leader throughout her 20-year career. She's been working on improving access to affordable, high-quality care for all people with a focus on vulnerable populations through her direct care, medical education, and administrative roles. Before coming to ONC, she was the New Orleans Health Commissioner and Mayor Mitch Landrieu's Senior Health Policy Advisor. Before joining the mayor's administration, she was a professor of medicine and vice dean for community affairs and health policy at Tulane University School of Medicine. I'm sure Dr. DeSalvo will tell you some about her experience with Hurricane Katrina and how that changed the way that she fundamentally looked at electronic health records and how to allow patients to access their information online. She's also served as president of the Louisiana Healthcare Quality Forum, a National Association of Chiefs of General Internal Medicine. She's also served on the boards of the National Association of County and City Health Officials and the Society of General Internal Medicine. She has many accolades, one very exciting that was named last year. She's been recognized as one of Women of Excellence in Healthcare, named a Children's Hero by the Children's Bureau of New Orleans and Family Service, and in 2013, Governing Magazine named Dr. DeSalvo one of 9 public officials of the year. So as you might imagine, we're thrilled to have Dr. DeSalvo with us as our new national coordinator, and without further ado, I'll let her come speak. Thank you.
Thank you, Nora. Well, good morning, everybody. Good morning. Thank you in Louisiana. That's what we make y'all do. So y'all will get used to that with us, and you'll get used to the y'all also, I suspect. Well, I want to thank everybody for coming to our annual meeting. The team has worked incredibly hard, even in the face of unexpected nice snow, which turned out to be nice for some parts of the area, apparently not so nice for others, but a lot of cold weather, so that we could share with you some great information that is coming not only from our grantees, but from many of our partners, but also have the chance to hear from you all, as Nora said, about how we take ourselves forward as we pivot at ONC, but also in healthcare, to see that we're really making a difference on the ground for everybody every day in improving healthcare and health. I have been really honored to join this team. I know that you all know this is a dedicated, passionate, hardworking group of individuals at ONC, and I can attest to that after having been here for a week and a half. They care very much about the American people, about the providers who are taking care of them, and about making sure that we do it right and do it efficiently and effectively. So there's plenty of hard work going on in what we're expected to do around our standards and interoperability, around ensuring privacy and safety, and thinking about how we do a better job of getting payment reform into play so that we can get the outcomes that we all want to see through payment. I was honored, really, to be asked to join this team by Secretary Sebelius, and initially somewhat surprised, but as I reflected over the course of my career, it should have been no surprise to me. I think it was in the works somehow for some time, with the many ways that I have become engaged in the space of health information technology to improve care, not only for the patients that were sitting right in front of me in my own clinic, but in systems that I had the chance to run, or systems I had the opportunity to build, or even in my role in public health. And so indeed, I am more than a cheerleader for health information technology. I am actively engaged in this space as a doctor and as a leader and as a public health official. And I just want to share a few of my experiences with you all, and then talk a little bit about where ONC is going in the next decade of this work that we're doing. It is a story that I've told a little bit of, and it's important for you all to know about me, that I was raised by a remarkable woman who had 3 daughters, and she raised us without very many resources, and she was a single parent, But somehow my mom always figured out a way to make sure we had what we needed to not only grow physically, but grow intellectually and emotionally. Part of that was making sure that we were healthy, and that meant in many cases that she relied upon the safety net system, the public health infrastructure, the clinics in Austin, Texas, where I grew up. And she always, though, figured out a way for us to be insured in her meager budget, to set that aside, and then expected us to take care of ourselves and execute some personal responsibility to try to keep ourselves well so that we didn't have to take the system. She also was a person who modeled the importance of giving to others and the values of equity and inclusion and justice and the power of listening more than the power of talking, which, by the way, I've been talking about myself so much for the last week and a half. I do apologize for that, but I think in the beginning it's what I'm expected to do. At any rate, my mom, Elaine, was a really powerful influence on my life, and she supported us and created an environment that allowed me, against all odds, to get into medical school, which I did at Tulane, and I landed at Charity Hospital, which in the 1980s was a remarkable place if you wanted to see every disease, communicable and otherwise, that was a scourge upon society. And unfortunately, for many people in that community, because they were uninsured and because there was no primary care infrastructure, and really a lot of us as doctors were flying blind without good data or information, we were reacting to care, and people were, particularly people who were low income or people of color, were trying to get services, but having to do that in a way that was the most expensive form. That was in emergency room. And Louisiana historically ranks at the very top of emergency department use nationally, because it is the last source of care, but for many people, the first source of care. It was a way that I began to see medicine, and though it was a good training experience, over the course of time, it became clear to me that it was not what you would want for your family, for your friends, or for yourself. You would prefer that people had an opportunity to be well, to stay well, or to be able to get recovered or treated earlier in the course of disease so that you were not more likely to die from diabetes or cancer, as is the case for people in Louisiana, because there was not any upstream opportunity for you to have your disease prevented or identified. And so I, as Nora said, have spent my career not just taking care of patients in not only in the public setting, but in the VA setting and the private setting, and teaching and doing research and being an administrator, but really in all of those, using all of those levers and tools to try to create a better way for people to have access to care earlier in the course of health, hopefully, or disease, as the case may be, so that they can have all the fulfillment of life that they deserve, frankly, so that health is an afterthought, and they're able to go to school and work and church and be with family and do all the things that we all take for granted if we're healthy, because that is ultimately the end game. My experience at Charity, though, was really rich, and it was interesting because it was paralleled with my time at the VA, which concurrently was adopting electronic health records, electronic scheduling, thinking about quality measures and quality improvement. The public hospital was beginning to think about it, but wasn't quite as advanced as the VA system. And so this was one of these great real-world experiences where on one side of the street, I was learning some best practices and literally being able to bring them to the other side of the street, because those two hospitals are across the way from each other, to apply them in that setting. And we had some success. As any of you who have been academics know, that sometimes the chair of your department just says, by the way, tomorrow this is your job, and that's what you do. And so I had the great distinction of being asked to fix the resident clinic for our chair of medicine at the time, a role that I really wasn't interested in because it was broken and outpatient medicine was so painful to practice. And who would want to do that? I wanted to be inpatient services. So I got the job and set to work of making it better. And it was probably one of the best things that ever happened, because it was easy to see where all the broken parts were, because I wasn't so invested in it and I hadn't been immersed in it for a long time. And just to give you an example of the minimal tools we had, but the kind of thing that got me really excited early was the implementation of electronic scheduling in our medicine clinic. And we went from having a 12-month wait to a 2-week wait, simply because we moved away from a system where someone answering the phone reached behind them and blindly grabbed a chart, that had the next available appointments for the residents, but instead had a system in front of them that pulled out the next available appointment. Because all these charts were in a rack, and if you grabbed the wrong one, it looked like it was a 6-month wait, but if you grabbed the one just next to it, it could have been a 2-month wait or a 12-month wait. We took the randomness out of that for the patients, and were able to actually automate the system. Now, you all know who are involved in change on the ground. You don't just do that. We actually had to physically take those charts away from the scheduling desk and ceremoniously lock them in a file cabinet and put the key in the pocket and walk away and said, we're done with the paper, and we're going to actually use this electronic system that we have and schedule. And it worked, and it was exciting to me to think that you could automate a system, educate a workforce, get them to be a part of the process, and give people better access to care, right? So they didn't have to wait 12 months just to get in to have their diabetes taken care of. Series of things like that we did in those early days, but continued on in my career of research and leadership, and was really enjoying my time in academic medicine, seeing patients and teaching, when we were visited by Hurricane Katrina in New Orleans. And as many of you know, and if you don't know, you will know after you've known me for some period of time, Katrina did not hit New Orleans. It took a little leg to the east, and it destroyed the Gulf Coast of Mississippi. What happened to New Orleans was not a hurricane event, but a flooding event. The levees failed under the intense pressure of the storm surge. They were not built to spec, and so the worst case scenario happened. The town filled up with water, and we were flooded for about 30 days under mandatory evacuation, and 1,800 people died as a result of that storm. We had 200,000 households flooded. In some areas around New Orleans, every single structure was flooded. In St. Bernard Parish, every single structure was flooded. So the healthcare system, being part of that, was completely shut down by and large. There are a few hospitals on high ground that remained open in the periphery, but even 911 services ceased to work. We scrambled to put all that back together initially, because there were still people in town, and there were first responders who needed services. After we were able to evacuate the hospital, there were still things happening in our city. But it was also a really, hopefully, unique time in American modern history when an entire area stops because all of the bricks and mortar are closed, all the usual relationships are torn apart, everybody is in the diaspora, and you take a moment to think about, are we going to put back together what we had, or are we going to try to take an opportunity to really reform our system? And in our case, it was reform the healthcare system. This was not just delivery reform, but financing reform, and thinking about what were the other key tools that had to happen. We spent time and energy working on building consensus. We had a set of principles and developed a blueprint at the state level for how we would want to see healthcare look in our state going forward, so that we would give everyone in our state, no matter the color of their skin or the source of their payment for services or where they live, the opportunity to have quality health care and to be healthy. This was as lofty as it sounds. This is what we put on paper. And the process led us to a 4-point plan, which included delivery system reform largely predicated on transforming primary care. We happened to be locally coinciding with what was nationally occurring with respect to patient-centered medical homes. I always say we got so lucky because we got to jump on that and use that framework to think about better primary care. The second key component was that we needed to have the tools available for providers to do the work they needed to do efficiently, effectively, and safely. For us, that meant health information technology. We had seen acutely that the paper systems don't travel well in water, and that now's the time for my really bad joke, and then y'all get used to me, which is in New Orleans. Who's been in New Orleans? Of course, a bunch of H. Of course, for hymns, everybody was there last year. So you've seen who's seen our cemeteries? Yes, we bury our people above ground because there's water below the ground. But we put our paper medical records below ground. So you can imagine all of our legacy systems were gone because there was no paper, because it was all bricks and flooded. At any rate, the truth is we had the opportunity because that was all flooded, literally, or because we saw that there was a better opportunity to have data follow patients if they had to evacuate in disaster, but also every day. And that you needed to see when you all know that as a doctor or a provider of any sort, you need to see what's happening, not just to that patient and what happened to them retrospectively, but what might happen to them in the future, what's happened to them across the continuum of care and all of the patients in your population that you care for. And we were doing so much planning. It was essential that we had this in a format that was not just an electronic health record, but we could begin to exchange. We focused on quality because we are the worst in the nation, and we wanted to move that and have an opportunity to actually have a conversation about quality that wouldn't be name, blame, shame, but that would really focus on process improvement and get every provider to a place where we could say that we were going to make a difference in the kind of care that was delivered. And finally, we talked about financing reform and payment reform, getting everybody in the tent, expanding coverage, and changing the way we paid for care so we supported and rewarded good primary care, health information technology, and quality. We've made a lot of progress. The story is not about that so much, but only to tell you that all along the way, it was clear to us that we could not do any of this without the right information technology infrastructure. And it's clear to me that everything we're trying to do in this nation is predicated and dependent on it. So when asked to be a part of ONC's future, I said absolutely yes, because this is a critical pillar in what we need to do in this nation to reform the healthcare delivery system. We have been making strides to expanding coverage and getting everybody in the tent, as we say at home. Our challenge now is to see that when everybody's in the tent and has access to care, that care is as effective and efficient and safe as possible, and that everyone has an opportunity to experience that we raise the floor. Not to say that we don't want to have aspirational models which exist all across the country, and I heard so many exciting stories yesterday from our grantees about things that many of us dream of that are actually happening in communities in America, and I know that we can diffuse that to other communities if we break down some of those barriers. The last piece I want to mention before I close is about public health and preparedness, because you won't hear about it a lot maybe initially, although you might, but I do believe that my experience in Katrina and then in several subsequent events, power outage events when I was health commissioner, have brought home to me that health information technology is not only valuable or necessary or an important tool in healthcare delivery. It is essential in public health. Public health does not have strong data systems, but we're so dependent on it in this country we don't even recognize. We depend on public health to protect us from disease, and those sometimes can be pretty significant. Diseases that we forgot we might be at risk for, like smallpox or polio. But the systems in place could be really enabled through the infusion of data that's happening in the clinical environment. Similarly, preparedness is an area where this country does well. Increasingly, over the last few years, we learned a lot in Katrina. We learned a lot from things like Superstorm Sandy and other power outages about those most frail and vulnerable in our community. You know, very often we forget that there are homebound folks who are electricity dependent or mobility dependent, and in the event of disaster, it's pretty hard to help them and get them out if you don't know exactly where they are and who they are and how to get them the resources that they need. And so even while in New Orleans, I had the chance to work with Nikki Lurie, who's the Assistant Secretary for Preparedness here at HHS, to use data to identify high-risk individuals in our community, who were Medicare and were oxygen dependent. Really wonderful experience as the health commissioner of a city because I didn't know all of the people who were at high risk in my community, but I knew there were a lot. And I knew there were a lot because we had a little thing called Isaac. We have a lot of storms in Louisiana. But Isaac was not a hurricane, it was a power outage event. And we ended up going door to door, as many people did in Sandy, trying to find the elderly and medically vulnerable to help them. And what we discovered was there were a lot of folks out there that we didn't know about, even in our medical special needs registry. This is a way that we, in public health across the country, try to figure out who's at high risk, and we get on television or the radio and ask people to call in and register themselves. Well, you can imagine how challenging that is for somebody who's 85 years old and lives alone and is in a wheelchair and is partially blind, right, and has some hearing loss. And as you would expect, what we learned using claims data, mind you, this is not data as rich as what we can get from a health information exchange, for example, was that of the 618 people that we were able to identify through the Medicare claims data as being oxygen dependent, we only knew of 15 of them in the health department. So the gap was about 600 people that were in need of my help as health commissioner that were known to the healthcare world because they had dropped a claim in Medicare, but hadn't registered with us to be assisted in the event of power outage or hurricane or disaster. And what a relief to know that now, and now the person who is following me has that information available and can be helpful in the event of preparedness. I tell you all that to capture your imagination about sort of the kinds of real world, really important, incredibly valuable, life-saving things that we can do as we begin to sew together the information that's coming into the electronic health records at the point of care through other mechanisms and then becomes interoperable and into a form that is useful at not just the population level but for public health and preparedness. So as my predecessors have told me, we're starting the next decade of ONC. I don't know if that means we only have 2 decades. I hope not, because I think the work is essential. But we have finished one. And it was a really busy time of growth, and there was major investment on the part of the American people in the structure of health information technology in this country, a lot of advancement in appreciation and implementation and adoption and workforce and innovation around sharing and beginning understanding about the needs around safety and privacy, et cetera. We have work to do going forward that is even more important, more challenging, but I can think of no finer group of people to do that than you all. We are ready to be your partner. We know that we have work to do ahead to ensure that the information meets expectations and standards and is useful around informing payment reform and informing better delivery of care. We also know that the information has to get in the system, and so the systems at the front line have to be usable so that the doctors actually want to interact with the electronic health record, or the nurses or others to put that critical information in that's going to eventually not just save money or improve the quality of care, but literally save lives. So think about that as you're listening throughout the day and as you're doing your work back at home. I am, as you will learn, a person who believes in working with everyone, because it takes a lot of minds to come up with the innovative ideas. And so we welcome your input, and I mean that genuinely. We look forward to seeing how we can work together to raise the floor so that we do everything we can to touch every American with this sense that their health information is available to help them at the point of care and help their doctor make the right decisions for them, but also to help them even more broadly than that, so whether it's saving their money, because ultimately it's theirs that they're paying, or saving their lives in the future. But also, please don't stop dreaming, because that is where we get these fabulous ideas and where we see aspirationally where we all want to go eventually as a country, so that this is like good health, an afterthought. Health information technology may just become an afterthought, a little bit like our cell phones. Thank you all very much, and I look forward to meeting you today.